Whenever you're ready.
The aim of this presentation is to refresh all staff who will be working in the community on completing a chest assessment and to familiarise you all with common respiratory medications. Like any other physiotherapy assessment, it's best to follow a format which helps you order the information you gather, as this will mean you can establish a problem list and clinically reason the treatment plan. So firstly, with the patient, you want to establish if they have a respiratory diagnosis like COPD, bronchiectasis, interstitial lung disease, tuberculosis. Then you're going to gather the history of the present condition. So you're going to ask them what's their main symptoms. It could be wheeze, shortness of breath, cough, sputum, chest pain. When did this start? Was the onset sudden or was it gradual? Are they getting better? Are they getting worse or are they staying the same? Any aggravating or relieving factors, and have they had any recent travel? And if they have, you need to refer to the Public Health Agency's guidance. Then you need to look at the past medical history, and you can ask this information off the referrer, or you can check NIECR, or you may need to rely on staff, maybe in a nursing home, or if you're out in the house, you may need to rely on family if the patient maybe has a level of confusion or isn't able to communicate the information themselves. Check if they're not sure of their past medical history and they live alone and you don't maybe have access to NIECR or you didn't gather it from the referrer, their medications while you're in the house would be a good indicator of any past medical history they have, and then you can check this by either phoning back to base or whenever you come back to base. Ask them also if they've had any recent infections, if they've had any trauma like a recent fall or if they've injured their chest wall. Have they had any recent operations, hospital admissions or any new diagnosis. Check and see if they've any allergies, and also just be aware of any coexisting diseases like osteoporosis that may have contraindications to a treatment that you might be thinking about. Gather your normal social history. You're really trying to establish, has the person sufficient support to stay at home? Or do they need any additional services? For example, do they need an increased package of care or a manual handling assessment to determine if they need any equipment? For example, a walking aid, toileting aids or manual handling equipment. So what you want to know is what type of house do they have? Do they have stairs? Is the bedroom, the bathroom, the toilet upstairs or downstairs? Are they still working, and if so, what's their occupation? Do they live alone? Do they have a current package of care, and what is it? And what's their level of dependency? And also if they've any input from any other services, so maybe if district nurse comes in regularly, then that might be a good profession then to link with. Then if you're putting a treatment plan in place, just making them aware that maybe you have made changes. Then look at their drug history. If they're not sure of what medication they're on, NIECR is a really good information tool and you can get their medications from it. If you're in the house and they have a blister pack, the medications will be listed on it, or they may have a medication box as well. The one thing that you need to ask is, have they been taking their medications as prescribed? And just check if there's any recent changes, because maybe there has been and the person has been a little confused or maybe not adhering to these changes, and this might attribute to some of the symptoms that they might be having. Find out if they have a home nebulizer, and if they do, you want to know, have they been using it frequently, and if they have, what's their normal use? So is it BD and then maybe they've been using it QID and it has been effective, or maybe they've been using it more frequently and it hasn't been of effect. Find out if they have oxygen, and if they have oxygen, is it LTOT, is it ambulatory, is it short burst? Do they have concentrator and do they have cylinders? And what giving device do they use? Is it nasal cannula or is it a face mask? And this could be important if they're a chronic mouth breather, or if they are now a mouth breather due to a blocked nose or maybe increased shortness of breath, because they may benefit from a mask which can be sourced quite easily. Ask them what the prescribed flow rate is and document that as well. Find out if they have home ventilation, and if there is it CPAP or is it BiPAP, and how many hours a day are they supposed to be on it, and how many hours a day are they actually tolerating it. Also ask them if they're a smoker or were they an ex-smoker, and check for e-cigarettes, pipes, normal cigarettes and rolled cigarettes as well. This is important as the Chief Medical Officer has highlighted that smokers are more susceptible to respiratory infections. Smoking reduces the body's natural protection against infections and viruses. These risks are also greater for people exposed to second-hand smoke, including children. It is important to be sharing clear messages about the need to not smoke in the home. And considering one of the main treatments for COVID-19 is oxygen, the risks of oxygen and the smoking status needs to be clearly identified and reviewed very carefully. So moving on, subjectively, establish the normal baseline for the patient, and if the patient isn't able to tell you, relatives are always a good source of information. Their normal exercise tolerance, so if they're normally able to go out and about independently and they're having difficulty moving, say, from room to room because they're more short of breath, then this is a big change. Do they have any night symptoms? Are they wakened at night with coughing or breathlessness? So then moving on to palpation, because out in the home we don't have any ability to maybe take x-rays or do extended tests that we can do in hospital. So just some simple things that you can note is if you're happy enough to just feel the person's neck or the lymph nodes swollen, this may be a sign that they have an infection. Look at the colour of their skin. If it's quite pale, it could be early signs of hypoxia. They could have a low HB. If it's yellowy, they maybe could be jaundiced. Look at the condition of their skin as well, and also feel the temperature of their skin. Do they feel hot to touch, or do they feel cool? And maybe do they feel sweaty or clammy? And also their skin could be very, very dry, and they could be dehydrated. If you're happy to put your hands on their chest wall, then you can feel the expansion in their lungs and feel, is it equal, is it reduced apically, or is it reduced basally, or maybe on one side or the other. Temperature, if they don't have a thermometer, you can just feel, do they feel hot to touch on their chest or on their back. Also just check if their trachea is central as well, and you could have a look to see if they've any dependent oedema or if they have any ankle edema, and you could ask them, is this normal for them or is it worsening? So just moving on to the observations, try and establish, is their mental state, is it normal, is it altered, or is it confused? And if they are confused, is this long-standing confusion, or maybe is this new confusion? Look for any dependent oedema and ask, is it long-standing, is it new, is it moderate, or is it gross, is it pitting oedema? Look at the position that the patient is sitting in. Are they quite comfortable how they're sitting, or are they very guarded? If they're very, very guarded to a particular side of their chest wall, it may do no harm to maybe ask them, would it be okay to expose the side of the chest wall just to check that they have no injury there, and maybe just ask them a few more questions around that. If maybe they're in the forward lean position, well then it might make you think that they're using their accessory muscles and they're working a little bit harder. So is their colour, is it pale? Are they flushed? Are they cyanosed? As we said earlier, pale could be early signs of hypoxia, and cyanosis is more later signs of hypoxia. Peripheral cyanosis is more indicative of respiratory issues, and central cyanosis is more indicative of cardiac issues. But just be aware that you could see a combination of both. And for anybody who's not familiar, peripheral cyanosis, you would be looking at the nail beds, and central cyanosis, you would see it around the lips and the mouth and the nose. Look for signs of increased work of breathing. Are they pursed lip breathing? Are they able to talk in full sentences without taking a breath? Are they using their accessory muscles? And what is their pattern of breathing? Is it very, very shallow and rapid? Or is it deeper and slower? Do they have any chest pain or pleuritic pain? So if it's none, that's good. If they do have pain, is this pain that they do have from time to time, or is this a new presentation? And find out the site, the nature, and what increases it or what decreases it. You can also just look at the hands. You can look for any nicotine staining, so it would tell you about their smoking status. You'd also be looking for a tremor, any cyanosis, and also a CO2 flap, which might help you to see if there's any signs of increasing carbon dioxide. So what you want to do is get them to hold their hands up as if they're stopping traffic, and if they have a CO2 flap, it's a very noticeable flap forward of their hands. And then finger clubbing. So I'm going to move on to the next slide just for finger clubbing, just to give you a few pictures of finger clubbing. Finger clubbing is an increase in soft tissue around the ends of the fingers and the toes, and it changes the shape of the nails. The nails curve more than normal, and sometimes the ends of the fingers may become enlarged as well. And if somebody has finger clubbing, they're probably very well into their disease process and potentially towards the end of their disease process. So here we have a table now of the observations. So the values at point 2 in each of the sections are cause for concern in the community, but you may be able to treat the patient in the community with the relevant support and treatment and monitoring. However, the values at point 3 in each section would indicate a necessary discussion with medical staff, whether that be a consultant or a GP, and it likely might mean an admission to hospital for the patient. But just remember, no one value can be looked at in isolation and must be looked at in conjunction with the full clinical picture. So if we look at the heart rate is important, but the quality of the pulse may provide information regarding cardiac output also. So make sure that you feel for the pulse manually as well, and feel if it's bounding or if it's thready or if it's irregular. So looking at the blood pressure, so the blood pressure, just to refresh us all, the systolic pressure is the higher number, and that is the force at which the heart pumps blood around the body. And then your diastolic pressure is the lower number, and this is the resistance to the blood flow in the vessels. So everyone's blood pressure can be slightly different, and just remember what's considered low or high for you may be considered normal for someone else. So it's some patients who maybe have blood pressure problems are very aware of what their blood pressure is normally. So if they're able to tell you that, that's a really good starting point. So then temperature. A high temperature is feeling hot to touch on the chest or on the back, and if you don't have a thermometer, you don't need to measure the temperature. However, for COVID-19, they do talk about a temperature of 37.8 degrees or greater. So looking at respiratory rate, a normal respiratory rate is 12 to 20. However, just be mindful if somebody does have a respiratory diagnosis, their normal respiratory rate may sit slightly higher than this. So again, you need to take into account the respiratory rate in the full clinical picture. And then lastly, if you do have a SATS monitor with them, try to find out their baseline SATS. Normally our target SATS range for somebody with COPD would be 88 to 92%, and all other conditions would be greater than 94%. So after that, if you do have a stethoscope and you're able to auscultate the chest, then you're listening for the air entry, you're trying to listen for any wheeze, and then whether it's an inspiratory wheeze or an expiratory wheeze, and then you're listening for any creps. So you're listening for the creps, whether they're very wet creps, or whether they're coarse creps, whether they're widespread, or whether they're to a specific lobe or a specific region. And just I have put in there about the curb 65 for anybody who doesn't work on the community. They mightn't be familiar with it, but some of the community teams and the acute care at home team sometimes will assess this. So this is really for your information. You wouldn't be expected to complete this. It is the severity it's a severity assessment of community acquired pneumonia, and you get 1 point for each feature. So if they're confused, they get a point. If their urea is over 7, they get a point. If their respiratory rate is over 30, they get a point. And then if their blood pressure is in them ranges, they get a point. And if they're over 65, they get a point. So they get a total score out of 5, and the higher the score, the higher the severity of community acquired pneumonia. So just I've put in a picture, if you are going to auscultate the chest, just the surface markings of the lobes, so that you know that you're auscultating in the right places. So, talking about the cough then, you need to know whether do they have a cough. And for COVID-19, the PHA advised to establish, is this cough new and is it continuous? So continuous means coughing a lot for more than an hour, or 3 or more coughing episodes in 24 hours. Or if you usually have a cough, it just may be more worse than normal. So, is their cough effective? Is it dry? Is it moist? Is it productive? And if it is productive, is the expectoration easy or is it difficult? And if it is difficult, why? Then do they have sputum? Yes or no? And the volume over 24 hours, and we would normally ask them, normally would you produce a teaspoon, a tablespoon, an egg cup full, a cup over the 24-hour period? Is their colour white, creamy, yellow, green, grey, black? What is it normally and what is it now? And consistency, is it thin, is it thick? And also sometimes the sputum can be foul smelling as well. And is there any blood in the sputum? Okay, and we're talking about fresh hemoptysis, so we are. So questions then as well that you would like to know is, what is the ceiling level of care for this patient? Is there any advanced care plans in place? And is there a do not attempt cardiopulmonary resuscitation order on this patient in the community as well? So we've got all this information. So now we're going to try and put it together. So what you're trying to ascertain, is this a physiotherapy problem? So does your problem list include increased work of breathing, sputum retention and decreased lung volume? All these things we can do something about. And then we have pain and wheeze, and along with pharmacology, we can do something about these. So you have to think about, how is this problem best treated and what's going to be our treatment plan? And do you need to liaise with a GP or refer on to another service like the acute care at home team? So if we look at increased work of breathing, we have lots of treatment options. We can manage their breathlessness, we can use positioning, we can work in conjunction with their bronchodilators, their inhalers, their nebulizers. We can also use fan therapy, we can use relaxation, and I suppose you do need to consider, does this patient need oxygen? But you will have established that through your assessment. If they have sputum retention, then we can do our active cycle of breathing techniques with graded huffing. We can do manual techniques if they're not contraindicated, like perks and vibes and assisted cough. We can use our oscillating PEP devices. We can use our cough augmentation devices like your IPPB, your cough assists, your breath tracking. And some of these patients may already have suction in the community, so that might be an option. And some of them, if they're a tracheostomy as well, they may well have suction in the community already. Decreased lung volume, so you'll be thinking about your thoracic expansion exercises, the positioning that you're doing these exercises in, incentive spirometry, and then your cough augmentation like your IPPB, your cough assist, and your breath stacking. So pain, you really need pharmacology for pain, so you need to liaise with your GP, but we can also advise them on positioning if they are in pain, work in conjunction with the analgesics, and we could do some relaxation or teach them some relaxation techniques. Again, with wheeze, you want to liaise with your GP to get them pharmacology, so you might be thinking about nebulizers or inhaled steroids. Again, positioning is really, really important too. You're going to work in conjunction with your bronchodilators and your nebulizers, and relaxation is really effective with wheeze as well. So just moving on to our main respiratory medications. There's a lot of different medications patients who have a confirmed respiratory diagnosis could be on, and I'm just quickly going to go through them. So you have your bronchodilators, which can be short-acting or long-acting. And these can be beta-2 agonists, which are inhaled or nebulized, for example, like salbutamol, which I'm sure you've all heard of. Your antimuscarinic agents, which can be inhaled or nebulized, for example, ipratropium bromide. Then you have your theophylline, which are a tablet and they're an add-on bronchodilator like Unifenol, or you have your montelukast, for example, singular. Antibiotics. They can be on acute course of antibiotics, or they can be on nebulized antibiotics like colamycin. And then your macrolides, which are your maintenance antibiotics, for example, azithromycin. These patients can be on corticosteroids, which are inhaled and oral, and they could be on them for an acute episode, or they could be on maintenance steroids as well. Lots of our patients could be on nicotine replacement therapy. There are lots of interventions out there, and if you have any concerns about what they're taking, or maybe that they have agreed for smoking cessation, you need to refer them to the specialist teams, the smoking cessation teams within the trust. Some of them may be on cough suppressants like simple Linctus or codeine Linctus as well. A lot of our patients would be on PPI, which is your tummy protectors, for example, your omeprazole. They could be on mucolytics, which help to thin the viscosity of the phlegm, and examples of them are mucodyne, carbamazepine, or hypertonic saline, which would be nebulized. If they have allergies, they could be on antihistamines like cetirizine. They may also be on a PDE4 inhibitor. These are relatively new in the respiratory world, and they would be prescribed by the respiratory consultant, but it suppresses the immune system and it helps to reduce inflammation. But a lot of the times the PDE4 inhibitors aren't tolerated very, very well, so they're not. Then if they are palliative care, they may be on palliative care medication like benzodiazepines, opioids, or medication for hypersalivation. They could be on oxygen, and the details will be in other presentations that are on SharePoint. And some of the patients with interstitial lung diseases may be on antifibrotics, for example, pirfenidone. And again, sometimes these aren't very well tolerated, but they would be prescribed by the consultant, and they would be monitored by the consultant and the hospital pharmacist. There's lots of different inhalers out there. There's short-acting bronchodilators, which you'll hear people calling SABAs, long-acting bronchodilators, which people will call LAMAs, the short-acting muscarinics, the long-acting muscarinics, SAMAs and LAMAs, and then your inhaled corticosteroids. Some of the inhalers have single drugs in them, some have combination inhalers, so they could have up to 2 or 3 drugs in them, and if you look at the pictures you'll just see there's a whole host and raft of devices out there. But the devices will either be aerosol generated inhalers or dry powdered inhalers. Irrespective of the device, it can only be one or the other. The device needs to match the patient's ability, so if you think that it's not matching the patient's abilities and your specialty isn't respiratory, come back to the respiratory team and we will certainly review that. The technique is the utmost important, because if they're not getting the drug delivered into the airways and they're not getting the maximum amount of drug into the airways, well then it can't provide the maximum benefit to the patient. So there is lots of training devices that we will use out there to assess which device is the best for the patient. Aerosol generated devices, so these devices administer the medication with pressure, therefore the patient only needs to guide the medication into the airways. So if they're using an aerosol generated device, they do a slow deep breath if they can, hold for a count of 6 to 9 seconds if possible. So they're inhaling slow and steady. Okay, so the mistake they tend to use with the aerosol generated devices is as soon as they press the device, they tend to inhale quickly. So you want to ask them, the device will generate the energy, all they need to do is guide the medication into the lungs. So the inhalation is slow and steady. If they're using an aero chamber, there's 2 different techniques that they can use with the aerosol generated device connected to an air chamber. They can either deliver the device and then slowly breathe in, hold for a count of 6 to 9 seconds if possible, and then breathe out through the nose. I always tell them to take a second breath in through the chamber just to make sure all the medicine is out of the chamber. The other way they can do it is they can deliver 1 dose into the chamber and then they breathe in through the mouth and out through the nose, slow and steady, 5 times. They need to wait 30 seconds between each puff, because sometimes it takes about 30 seconds for the medicine to reload in the canister. So you will see people who press the canister straight after each other, but the problem with that is the second puff might only be aerosol and there might not be any medicine in it. So just remind them to deliver their first puff, do their breathing, wait 30 seconds and then deliver their second puff. That's just a picture of the aero chamber and mask, and sometimes they will get a mask that covers the mouth and nose, and the top picture then is they put that into their mouth. So they take the lighter blue cap off and there's a mouthpiece and they put that into their mouth, and they must make sure that they have a good tight seal around the mouthpiece. These devices are great for people who are very short of breath and who can't they don't have a great inspiratory force and they're not really able to hold their breath. These devices are great for them. So moving on to the dry powdered inhalers, the patients need to provide the energy for the drug to be deposited into their lungs. So if you think about the device, the powder is sitting in a capsule in the device, so they need to be able to breathe in hard enough to draw the powder up out of the capsule, up into their mouth and then down into their lungs. So with any dry powdered inhaler, the technique has to be a hard and fast deep breath in, hold for a count of 6 to 9 if possible, and then breathe out through their nose. So with the dry powdered inhalers, it doesn't matter what the device is, you need to be telling them they need to breathe in hard and fast and deep and hold their breath for a count of 6 to 9 seconds and then breathe out through their nose. And there is lots of training devices that we can give them. So if they are able to do the inspiratory effort needed, the device will whistle and let them know that they're able to do it correctly. So whenever they go to take the dry powdered inhalers, load the device. There's all different ways to load the device. And then they breathe out fully. They put the mouthpiece between their lips and their teeth, sealing with their lips. They breathe in steadily, with force and deeply. Hold for 5 to 10 seconds or 6 to 9 seconds and then breathe out through the nose slowly and repeat if necessary. So if you have any questions about any specific respiratory medications, there is the telephone numbers and the email addresses and a mobile contact numbers for the 3 teams sitting in the Craigavon and Banbridge area, Armagh and Gannon area, Newry and Mourne area, and we're more than happy to take your call and discuss with you over the phone if you do have any queries.